All right, well, we are going to get started today with our Preparing for Back to School and Flu Season webinar. Olivia, if you wouldn't mind to advance to the next slide. I wanted to welcome everyone. I'm Kristen Fluitt, the Senior Quality Manager here at the Ohio AAP, and we want to thank you for joining us today. We have a lot to get through, so we are going to go ahead and get started, and we are recording this webinar, and the slides will be also available to you. As we have continued to move through the current pandemic, the chapter has continued to plan and think of ways to support Ohio's pediatric providers. And certainly at this point in time, when we're all looking into the fall and return to school, we are hoping that the information and resources we provide today can help support all the important work that you're doing. Never hesitate to reach out to us if you have additional needs or resources or questions. A few housekeeping items in an effort to control the background noise, because we do have a number of folks on the webinar today. We will be muting everyone. You will be able to chat in comments and questions in the chat box, and our panelists and staff will be chatting back answers. Also, feel free to share your own experience and strategies as you are preparing and helping support families as we transition into the fall and school time. We will be saving and sharing a chat transcript following the webinar. And let me just quickly review with you how to chat in your comments. You'll see on your screen down at the bottom or top sometimes a little bubble, and if you just click on that, that will take you to the chat box and you can type in any questions or comments that you have, and we'll monitor that. Olivia, if you could move to the next slide. Also, toward the end of our webinar today, we're going to be having a roundtable discussion around some submitted questions and then other questions that may come up. You can join that discussion by raising your virtual hand, which you should see a hand button that you're able to click, and that will let me know that you want to be unmuted. You also could chat that in if you want, and we will make sure you're unmuted and can join the roundtable discussion. Next slide, please. And again, just want to remind you that the webinar today, we're really excited to provide that to members. If you've not had a chance to join or your membership has lapsed with the chapter, we will be sending information after the webinar for you to renew your membership or join the chapter. Next slide, please. Our objectives for today are to increase knowledge of best practices for the back to school rush, and also increase knowledge of ways to prepare for the anticipated challenges during the upcoming flu season. Next slide. And just a brief introduction of our panelists today. We want to again thank them so much. They've put in so much time and work into preparing for this webinar. With us today, we have Dr. Michelle Dritz. She is an adolescent medicine physician at Cornerstone Pediatrics in the Dayton area. She is a delegate at large on the board at the Ohio AAP. Also joining us is Dr. Chris Peltier. He is a pediatrician at Pediatric Associates of Mount Carmel in the Cincinnati area, and he is the president-elect of the board at the Ohio AAP. As well, Dr. Denise Warwick is joining us. She is a pediatrician at Group Health Anderson in the Cincinnati area, and she is a delegate at large on the board at the Ohio AAP. Next slide, please. And I will turn it over to Dr. Peltier.
Thanks, Kristen. Olivia, can you advance the next slide, please? So we're going to start out the webinar with a brief review of the national AAP recommendations for back to school. And I want to sort of preference this entire webinar by, number one, saying that Denise, Michelle, and I, while we have been involved in talking to our local schools and our practices, I don't think any of us would say that we're experts on how to do this right. So we are really using this opportunity to learn as much from you all as hopefully you learn from the information we're going to present. I don't think there is a right way to do this. We're going to share some things that both the AAP and the Ohio Department of Health have shared as far as guidelines. And obviously, this is a moving target and things are changing. I think things have changed dramatically in the 2 weeks since I was asked to join the governor when he presented his back to school guidelines. And things may change drastically today after 5:30 at his press conference. So we're going to start with the AAP guidelines. And in general, those guidelines say that the AAP strongly advocates that really all considerations for the coming school year should start with a goal of having students physically present in school. However, with that big asterisk with the goal of safe return to school. And I think initially when these guidelines were first put out, some in the media and also some in government sort of took this as, well, the AAP says that all students should be in school. Yes, we think that it's the best plan for kids to be in school for their health and well-being, but there has to be policies to ensure that that's done safely. Next slide, Olivia. So as we know, as pediatricians, schools are fundamental to the development of our children and adolescents. They provide children with, obviously, the importance of educational and academic instruction, but also social and emotional skills, safety, healthy nutrition, therapies such as occupational, physical, and speech therapy, mental health counseling, physical activity, and obviously many other benefits. Next slide. So in addition to all of those things I just mentioned, we know that schools play a critical role in addressing racial and social inequality. So when we're dealing with our most vulnerable children, we have to really look at the ideal goal of getting kids back into school for all of these benefits. And this is a partnership between pediatricians, families, schools, and communities. And we all have to weigh in on the best and safe way to do this. And what works for one community may be different than what works for another community. And really, I think the guiding principle should be that the policies that school boards develop or private schools develop should support the overall health and well-being of all children in context of including their families and communities. Next slide, Olivia. So these policies have to be flexible and nimble. And what we say today may be different than what we say in 2 weeks or in 2 months. We have to be able to revise and adapt to what's going on with viral transmission, both at the community level as well as within a school. The policy should be practical, feasible, and appropriate for the student's developmental stage, which is really important when we're talking about masking. And we have to have special considerations to account for the diversity of children in our school systems, considering specifically those that have complex medical health conditions, that may live in poverty, or have developmental or healthcare needs or disabilities. Next slide. We know that one of the reasons the Academy so strongly said that the goal is for children to be back in person is because reducing social isolation is key. We know we're starting to see some evidence, and I know anecdotally in my own practice, I've seen that kids that were socially isolated during the March and April and May quarantine were showing more signs of depression and anxiety. And then the importance of identifying student needs, both social and emotional, mental health, and the concern that we were seeing, we were missing opportunities to screen children that may be subjected to physical and sexual abuse because other adults were not laying eyes on these kids. Next slide. And I can't overstate this whenever I talk to a parent or a school board. While our goal is to mitigate risks, we're never going to completely eliminate all risks. It's just not going to happen. And so we have to educate the community and families before school resumes about best practices to help them mitigate these risks and try to lower them as much as possible. Next slide. So let's look at a little bit about what the Academy recommended. So the first guideline has to do with physical distancing. Most of you know that the Centers for Disease Control guidance was that desks and children should be 6 feet apart. If you look at the AAP guidelines, they commented that in certain circumstances with proper masking, that distance could be 3 to 6 feet. And they cited an article that was published in Lancet saying that looking at, I think it was a retrospective, looking at studies, about 70 different studies, they said there's probably not much difference when masked of disease viral transmission from 3 to 6 feet. Obviously, we want to encourage social distancing between adults for 6 feet. I think definitely we know there's a higher degree of spread between adults than from children to adults. And then considering some great specific things. So for the younger kids, pre-kindergarten, preschool classes, we can cohort those classes to decrease crossover. And when the weather's nice, utilizing outdoor space as much as possible. We know from evidence that we're learning that the disease does not tend to spread as much in outdoor spaces as it does in indoor spaces. For elementary classes, spacing of desks, again, 3 to 6 feet with masking, cohorting, and also using outdoor space. And then secondary schools, again, the spacing of desks, considering block schedules where maybe we cohort students that are all taking the same classes with each group of students. And instead of having the kids rotate from classroom to classroom, having the teachers rotate from classroom to classroom to sort of decrease those mingling in the hallways and those other common areas. Next slide. Busing is a unique circumstance that I think needs to be addressed. Ideally, encouraging parents, if they have the means, to encourage alternate transportation and avoiding having a lot of kids on the bus. I think importance of symptom screening at home prior to boarding bus, having parents take temperatures and do symptom screening, and educating our families to not send their kids to school if they're ill. Having assigned seating on the bus, again, social distancing, ideally 6 feet, and wearing face coverings for both the students as well as the bus driver. And then no other adults on the bus unless absolutely necessary, like maybe a student aide, if an IEP were to call for that. And then windows open if weather permits, again, trying to increase airflow within the bus. Next slide, Olivia. Let's talk about face coverings for a minute. So face coverings should be used as possible based on developmental capacity and feasibility. It's critical for the adult staff, teachers and administrators, to wear face coverings, particularly if they're going to be closer than 6 feet with students. Obviously, special considerations, when you're dealing with teachers that may be doing phonics lessons or foreign language, there may be some difficulty with that. So I think our teachers have to take that into account. And then personal protective equipment for school-based medical procedures should be based on current recommendations. So if we have a child that gets ill during the school day, the school nurse should have appropriate PPE to be able to be with that child while they're isolated, while they're waiting for a parent to come get them. Obviously, for pre-kindergarten and preschoolers, face coverings may be difficult to implement. So trying to cohort those children, utilizing outdoor spaces may be higher yield than trying to get those young children to wear face masks. Ideally, for elementary and secondary, I think we should try to encourage universal face masks as much as possible if developmentally appropriate. Obviously, a child with significant autism and sensory issues may really struggle with wearing a face mask, and I think we have to consider that. For the younger kids, I think we could also consider maybe face shields. That might be another option for kids that have a trouble sort of wearing a mask. Next slide. Obviously, cleaning and disinfecting protocols, just like all of you have adopted probably more robust cleaning and disinfecting in our offices, schools need to do the same things. If you're going to speak to your school boards about special considerations, thinking about things like wiping down door handles, sinks and faucets in the restrooms, maybe not using drinking fountains. Obviously, restrooms are going to need to be cleaned more often. And then how are they going to handle cleaning of shared equipment like computers, keyboards, and gymnasium equipment? Next slide. And then screening and testing, which has been really one of the big discussions that I know we've been having here within the Cincinnati community. So ideally, temperature and symptom screening needs to be done every day. At some schools, that's going to be very difficult to do at school. And then what do you do with a child that shows up to school with a temperature? So having those children be screened ahead of time, maybe using some sort of GroupMe app or a web-based portal where parents can enter their children's temperature and sign off that they don't have any symptoms before they go to school, so that the school and the administrators know that. Please educate your families. I know you are, but telling them stay home if your child's ill and contact their primary care pediatrician. There's a lot of debate on whether to test prior to sort of mass school reentry. I've seen mixed things. I've heard mixed things. I know some colleges are requiring that. I think right now, in Cincinnati at least, we are not recommending testing prior to school reentry, as it will only give a false sense of security. All you're saying is that these children were negative. We know that symptoms can develop up to 2 weeks later. So I think right now, the indication is not to recommend mass preschool starting screening testing. Next slide, please. And then behavioral emotional support. Every student, every class is going to be different. We need to know that, remember, teachers remind them that these kids have been out of school since early March. They may not be ready to learn on day one. There may need to be some catch-up instruction that needs to be done. And schools and counselors need to be increased attention to anxiety, attention span issues, potential for traumatic stress with all of the anxiety that's been going on in the community. And I think we have to remind schools that staff and teachers are going to have their own emotional health needs, and the schools need to be able to support those, not only students, but also teachers. Next slide, please. And then finally, other things to consider: food insecurity. If we go back to not being able to have school face-to-face, how are we going to ensure that vulnerable children that need school meals are going to get those? Same thing with children with special needs and IEPs that are getting occupational and physical therapy. How are those going to be continued if we have to go back to long distance learning? Immunizations. This is a great time during the summer to remind families to get into your office now to make sure that their well child's and immunizations are up to date. Sports physicals. As of now, sports are still continuing to plan to happen beginning in August, according to the OHSAA. And in Ohio, they are still requiring yearly sports physicals. So now's the time to reach out, do recalls, and get your kids in. And then also speaking with parents about the option to keeping kids if they feel like, for whatever reason, they have an ill grandparent or an ill family member who's at risk, the pros and cons of doing schooling at home for those children. Next slide, please. I'm not going to read these slides, but the next two slides have some quotes from a joint position statement that was released last Friday. And I just want to point it out that, initially the AAP came out with their policy statement about 2 weeks ago, a little over. But I was very pleased to see that on Friday, there was a joint statement from both the Academy as well as the National Education Association, the American Federation of Teachers, and the American Association of School Administrators that really sort of supported all of the things that the AAP had talked about, really making a science-based decision on safely reopening schools, but trying to do that in a safe way. You can advance to the next slide. And that's just some more from that paper. So I'm going to go ahead and have Olivia advance to the next slide. I know there's a text question. I think we're going to address that at the end of the presentation. We have a roundtable. So I'm going to turn it over to Dr. Dritz to sort of compare and contrast the recommendations from ODH.
Hi, everyone. So my task, hopefully right now, is to give you guys a sense as pediatricians and medical providers what the current Ohio Department of Health guidance is for schools. So you have a clear understanding of what schools are being required to do when you're interacting and working with families. So if you can go to the next slide, please. And I'll start off by saying that there's really most of what the guidance is from the Ohio Department of Health is guidance and considerations with very few required mandates in it. The only state mandate as of right now by the state of Ohio as part of their reset and restart education document and their specific COVID documents for the K-12 schools is that teachers and school staff must wear masks, but otherwise everything else you're going to be hearing me talk about over the next few months really fall under this category of, like I was calling, guidelines and considerations for schools to use, with the state being very aware of both schools needing to have flexibility as well as schools within our state having very local control. So it really acts as a document to help guide schools, but it is grounded in many of those recommendations that Chris just mentioned through the AAP and the CDC, as well as various other educational, national, and state entities. And if you're looking to see the wording within both of these documents, I put the links down below, but you can also go onto the ODH's website and pull up both documents so that you can see them as well for yourself. You can go to the next slide, please. Both of the guidance really are certainly grounded in some guiding principles about us making sure as people who work within school systems that we're really coming at this from an angle of being caring both for our students as well as our staff and teachers, and really prioritizing the needs of those students and staff, but also creating an environment that's conducive to learning and effective for teaching, and is operating in a way that really is following as much sort of infection control as possible, but also promoting and allowing for flexibilities as schools need them, and as we may have flare-ups in terms of infection rates within particular counties or districts. Next slide, please. Like many other documents and guidance that we've seen both in work situations and healthcare situations, this guidance is not unexpectedly based on vigilant assessment of symptoms, sanitizing, social distancing, and face mask policies. So again, that is sort of the basis in which all of these guidances are going to be following. Next slide, please, though. There are a few key sort of medically relevant features of the Ohio Department of Health guidance, and that is, even though the only mandate was for teachers and staff to wear masks, they are strongly recommending face covering for students in the state of Ohio starting 3rd grade or higher. And as always, maximizing those health hygiene and hand hygiene practices with special considerations, and giving schools flexibility to modify how they teach students, especially those that are health vulnerable, either the students themselves or maybe families that may be health vulnerable. So again, giving flexibility for integrating different types of teaching strategies, including remote learning, as necessary. They also emphasize that schools should consider creative spacing and creative ways to help minimize interactions and maximize those spacing and the way students are taught. So as Chris mentioned before, things like split schedules and cohorting students, and using outdoors or non-traditional spaces. And there's another part of the guidance that really does discuss with schools trying to move away from the past use of perfect attendance, and to think more about consistent attendance, recognizing that this is going to be a school year where perfect attendance is very likely not going to be possible, and not to put that sort of pressure on both students and families, as well as school staff as well, and to not penalize students for missing school, especially missing school appropriately due to illness or specifically COVID issues. Next slide, please. The other few sort of medically relevant features of the documents is, again, allowing schools both the permission but also the flexibility to figure out how summer and school sports should look and work, as long as they're really trying to maximize social distancing and minimizing health risks associated with them. There's clear recommendations to continue to keep recess as part of the school day, and ideally in an outside environment, but it does recommend avoiding field trips unless they're going to highly managed settings. And the guidance is pretty minimal when it comes to what the Department of Health is requiring schools to do around bus transportation and cafeteria and basically sort of large group settings. But it basically asks schools to think creatively about how to address those. And Chris mentioned some of the recommendations from the National AAP. The guidance also gives schools flexibility and asks them to really think about not just health vulnerable patients and students and staff, but also just think about how to create a teaching environment for students for other reasons who may not be comfortable returning to school. So again, just really maximizing the flexibility that schools can use as they're entering this school year. And the Ohio Department of Health has said that they will continue to help both the education as well as have the Ohio Department of Mental Health and Addiction Services really support the schools in providing what will likely be some really important mental health resources to support the school this year. Next slide, please. There is not a ton of very direct guidance about what schools in the state of Ohio are going to require in terms of testing or when students are sick, but I've tried to sum up what is listed in the document, and I will say that some of the documents refer to what the current CDC guidelines are. So again, as those guidelines may change, that may make the Ohio school guidance change as well. But the current ODH guidelines say that if a student or staff is feeling sick, they should stay home. And they do use in their documentation a temperature of 100 or greater than 100. I think that's more just to help simplify things for families. But they say if there's a temperature greater than 100 or any of those typical COVID-19 like symptoms, those students or staff members should be staying home. If a student or a staff member develops symptoms while at school, there's language in the guidance to say that student or staff should be isolated, have a face covering if they didn't already have one on at that point. As Chris mentioned, making sure nursing staff and other school staff has availability of protective equipment to help with monitoring that student or staff member until they're able to go home as soon as possible. And it does say that the school should refer the patient, whether it be student or staff, to their healthcare provider or for a testing site, and that they should notify their health department in the case of a known positive or a suspected COVID case that was in their school building. If a student or a staff is diagnosed with COVID-19, the guidance says that families or staff should notify the school if they're being quarantined for that. And the language that they use for return to school is that they cannot return to school until they have met CDC criteria for return. And we'll talk about that in just a few minutes. There's also language in the ODH documents about if a student or staff is exposed to COVID-19. And again, it asks that families or staff notify the school, and it explicitly says that if there's a known exposure, including household contacts, for instance, whether it's a presumed case based on symptoms or a confirmed case based upon testing, then that student or staff must self-quarantine at home for 14 days. And they also have language in there to say that if staff or students travel to a place with known community spread of COVID-19, it gives the option that they may choose to self-quarantine at home for 14 days as well. Next slide, please. This is the CDC criteria as of May 29th, and that doesn't mean that's the last time I looked at it, but that's the last time it's been updated on the CDC website. And again, the link to the CDC's current guidance is down there below. But this is the current CDC's criteria, and therefore what the Ohio Department of Health is using for when students or when staff can return to work after a diagnosis of COVID-19, whether that diagnosis is based upon presumed symptoms, presumed infection based on symptoms, or confirmed through testing. So we're going to kind of go through this algorithm. Many of you may already know this by heart by now, but if the patient had symptoms and either presumed or confirmed with testing COVID-19, then they are free to return to school or work by one of two ways. They can either, us as providers can either clear them for return by a symptom-based strategy or a test-based strategy. If it's a symptom-based strategy, that means that the student or staff must have no fever for the last 3 days or 72 hours without using any medicine to reduce fever. 2, they need to have no or improvement of at least what CDC right now is saying their respiratory symptoms, so that those must have improved. And 3, they need to be at least 10 days since their symptoms first developed. That's a symptom-based strategy to return to school or work. If the provider decides to clear them based upon a test-based strategy, it's similar: no fever for the last 3 days without fever-reducing medicines, improvement in the respiratory symptoms, and 3, 2 negative PCR tests more than 24 hours in a row. That would be considered clearance as a test-based strategy, though many of you have probably seen the understanding that PCR testing may be positive for multiple weeks, up to about 6 weeks or so after the infection otherwise seems to clear. So in some cases, providers are leaning a bit more heavily on the symptom-based strategy rather than the test-based strategy. And I know that's what Cincinnati Children's is currently kind of helping their community pediatricians consider as part of how to clear someone to return to school or work. If a patient was diagnosed or a staff member was diagnosed with COVID, not because they had symptoms, but rather because they had a positive test, they also will eventually need to be required to cleared for rehome to school or work. And that also can happen in one of two ways: either a time-based strategy or a test-based strategy. So if it's going to be based upon a time-based strategy, then that person needs to have now 10 or more days now since has happened since they first tested positive for COVID. Plus, secondly, they must have never developed symptoms for COVID. If they ever did, then they pop over to that left-hand side of the algorithm, because then you're going to clear them as if they've had symptoms. Or the other way that a positive test can be cleared eventually is that test-based strategy, and that is based upon just 2 negative PCR tests in a row at least 24 hours apart. That is the current CDC criteria for return to work or school. Next slide, please. This information isn't specifically laid out in the ODH's school information around restarting, but as providers, it just helps us remember that as of early June, the state of Ohio has basically opened up what they consider priority groups for who can be tested if we feel like someone needs to be tested. And at this point, it's all the way through priority 5, which means basically anyone who's asymptomatic and otherwise not mentioned in any of the criteria above. So if you do feel like you need to test a patient for whatever reason, at least the current ODH guidelines is that we as providers are allowed to test if that test is available. Next slide, please. Same with this contact tracing guidance. This isn't labeled in the state ODH school restarting, but just keep in mind that the Ohio Department of Health is sort of simultaneously on a parallel track trying to do contact tracing for positive cases that they do know, and that process for families, in case you need to talk with families about them, is based upon recognizing that someone may have been in close contact with someone with COVID-19, and what they're using as close contact is basically the CDC's definition of anyone who's been within 6 feet of an infected person for at least 15 minutes, starting at least 2 days before the illness symptoms started, or if it was someone who is asymptomatic, but just based upon a positive test, up to 2 days prior to that positive test being done. But what will happen is if there's a positive test, the family obviously should be notified by their healthcare provider, and the healthcare provider should notify their local health department. And then the local health department will be notifying the Ohio Department of Health, and the Ohio Department of Health contact tracing personnel will be contacting families, though they do say that that will be a voluntary information about whether families can help them create a list of potential close contacts, so the Department of Health can reach out to those families to know when they need to be isolating as well. Again, all of these slides, I've tried to list the links to where you can find more information on the Ohio Department of Health website or the CDC. Next slide, please. There is and has been, multiple stages of reopening, obviously in the state of Ohio, including childcare centers that have opened prior to our own schools now that are about to open. And I know in some of our past discussions, there was questions about why discrepancies about being able to return to childcare 7 days in the childcare documents versus 10 days now. And the bottom line is this has been a moving target. And as the CDC's recommendations change, so has at least the Ohio Departments of Health's recommendations changed as well. So that one sort of snapshot slide that has the algorithm, or at least currently, of what that sort of requirement for return to childcare, school, work, whatever, is as of right now the most current guidance for that. Next slide, please. The other thing that I would sort of just emphasize, again, that's part of how the CDC is keeping in mind what we as medical providers, what they recommend that we be doing, is that if there is a patient who is in close contact with someone who is known to be positive for COVID-19, they do recommend, at least the CDC recommends, testing for all close contacts, whether that COVID-19 infection contact is a confirmed or a probable COVID-19 patient. The rest of this information actually is covered in that return to school guidance that we just saw a moment ago. So we can go to the next slide, please. The last two things that I'll just mention is in the Ohio Departments of Health school guidance, they make clear sort of phrasing about the fact that things may change, and that schools, they really put an emphasis on schools staying in close contact with their local health departments so that they can remain flexible in terms of what measures they need to be taking, both within the schools as well as potential needs to shift to online or whatever they need to do in the case of flare-ups. And if you go to the next slide, please, which is the last one, the state of Ohio now, as of about 2 weeks ago, I believe, has now tried to help both schools as well as the larger state understand what the current sort of lay of the land is in terms of current COVID cases and where potential flare-ups are. That's called the Ohio Public Health Advisory System, and that gets discussed by the governor every week as a way to sort of help recognize what's going on in the state and make hopefully targeted interventions based upon where we're seeing flare-ups. And it's based upon a series of medical indicators, and the more medical indicators a county has, the darker their color gets, all the way from yellow to orange to red to eventually purple at the highest rate. And that is in part what school recommendations are describing when they're saying using the information through our local departments of health to understand what's going on locally in your own county to really help guide what you may be doing next for your schools. So with that, that was my last slide. I'm going to turn it over to Dr. Warwick so we can really get a chance to talk more and really open up to some questions.
Excellent. Thank you, Michelle, and thank you, Chris. Go ahead and move to the next slide, please. So what we're trying to do with this discussion is to kind of make it more of an open roundtable discussion, since I know a lot of this is really flexible and kind of a moving target for most of us. Is that, a lot of the time, what we're not hearing as far as guidance from ODH or CDC, we're going to have to do as more office-based protocols and kind of coming up with, group decisions about how we want to handle this, or even getting a larger group of physicians in your community together to kind of come to a consensus about this. So the first and foremost one is the testing. So I'm sure your offices have been getting a lot of phone calls about asymptomatic versus symptomatic testing for folks. Our office has been grappling with this too about one, we're hearing guidance from the governor that, we should be robust in our testing to kind of be sure that we can contact trace and kind of pick up those asymptomatic carriers. But how do we do this, and how do we accommodate as many people that are requesting tests? So I think, what everyone, I would suggest is coming up with kind of a list for your practice of as far as where you would recommend people doing the testing, whether it's your local children's hospital, whether it's some of the community sites that are set up through ODH, through the state to get those tests, and then also knowing what the turnaround time for those tests are. So I know in our health system that we have the capability of doing testing at our office site, and our turnaround time is about 24 hours, as well as that's reflective of what our children's hospital is as well, but not so much for the testing through the state. And I think that can be variable as well. So just being able to tell patients about when to expect that. I've been doing my best to monitor through the chat box some of these questions, and one that had come up was, notifying patients about the quarantining. So, what we've been sharing with our patients is that we can still do the testing. However, even with a negative test, we can't be sure that you absolutely do not have COVID. And so the only tried and true way to be safe is to really recommend the quarantining for 14 days after the first exposure. So I think that's the safest bet to share with families. I think it sometimes can be hard for them to, to accept that advice as far as not being able to do anything for that 14 days, but that is the safest thing to do. As far as, I'm trying to make sure there's nothing else in the chat box here.
I added a comment about sort of the difference
sure.
between, because we were discussing this with Josh Shaston, who's an ID doc at Cincinnati Children's today, that different definition, and the media uses these interchangeably between quarantining and isolation. So quarantine is really for that exposure that's not positive or not ill, and isolation is really for that COVID positive patient.
Okay. So is there any difference? Did they specify about what to do exactly for the quarantine versus isolation?
So quarantine would be exactly as you described. It's 14 days to monitor for symptoms. Isolation would be somebody that's COVID positive. They should be isolated for 10 days, and then that 72 hours is symptom free before returning.
Okay. Perfect. Okay, excellent. And then we had received some local guidance from Cincinnati Children's regarding the best yield of testing is somewhere between days 3 and 5 of illness. Now I know all of us kind of the same thing would go for flu-like illness as well, that sometimes, we test too early, and there, it all depends on the sensitivity of the testing. But that's what we had heard in our local area. But I know that may be a moving target as we find out more about the testing moving towards the fall. Any other comments or questions about testing before we move on?
There's a question in the chat box.
Yeah.
So people are becoming more concerned about fragmented virus resulting in a positive test when they are in fact not contagious. Do we have any say about this? Anything to say?
I have not heard much about the fragmented virus.
I can address this because again we were just having this conversation with one of our ID docs today. That's he's recommending, like, once you're positive, if you're positive, you isolate for 10 days, you come out after those 10 days and at least 72 hours is symptom free. And he would recommend not retesting because, again, those patients may be positive still, but the risk of them being contagious is much lower. So, and that's
Great.
that's different than I'm guiding my kids' school, and there were some adult docs that were on there, and that's really big in the adult world, I think, of getting negative tests before returning. But from everything that most pediatric ID experts are saying, it's like they would recommend not retesting once they hit that 10 days and 72 hours.
Great. Perfect. Okay. And then the best timing for asymptomatic patients is another one that had come up in the chat box. I think this is a big question mark. I have not seen any guidance on this specifically. I would assume that, it seems like, 24 hours seems too soon. I think within, I would say, again, that 3 to 5 day mark would seem most reasonable, but I can't say for certain that that's the case. And Chris, have you heard any guidance on that from Josh Efson or any other ID?
I have
folks?
not, at least right now. I'm still struggling with, am I going to test? I mean, I know we're walking that fine line between public health and wanting to know, but I'll admit I haven't really, if it's not going to change my outcome and they're stuck for 14 days, I haven't necessarily been pushing to be tested. That may not be from a public health standpoint the right thing to do, but that's kind of what I've been doing.
Sure. Okay.
And just keep in mind that from the CDC's current guidance on that, if you do have someone that tested positive but is asymptomatic and you're trying to basically clear them early, there is no clear guidance, as we've said, about when to start to retest them, but you will still need technically 2 negative tests at least 24 hours apart in a row.
And for those of you that may be on the phone and can't see the chat, Dr. Jill Klein said that she had read something from Harvard that suggested 7 to 8 days from exposure, but again, question mark. So I think what we're saying is we don't really know. And even as Josh Shafson said today, we're still so behind learning, and we will learn more as we go through this, but there's a reason. There's many reasons, but this is one of the many reasons that things are getting so out of control because we just don't know enough about the virus yet.
Yeah. We'll address this one last question and then we'll move on to the next slide. So the next question I saw in the chat box was any guidance on quarantining classroom versus children sitting around a child during class when there's a positive child identified. I think the best guidance would be is to use the rules to return to school with the 72 hours fever free and at least 10 days from symptoms improved for the child that was positive. Also, the other thing would be is that if children are masking of their an age that it's appropriate for masking, that I think them wearing the mask is very appropriate, and that still using the minimum 3, ideally 6 feet of distance from those patients. But I don't think there's going to be any specific areas of the classroom where they're going to be isolating a specific student that was COVID positive.
I'm going to sort of make a comment here too. The schools are also, they have to report all exposures and positive tests to your local health department, and really your local health department is going to be the ones that are going to sort of be doing this. And so I think as pediatricians, we're not going to necessarily be weighing in on this as much because really the health departments, teachers have to go back. It's 48 hours within that close contact of 6 feet. It's 15 minutes of close contact exposure without a mask would be considered a close contact. So as you're if those of you that are advising your school districts, especially for older, like high school classes, one of the things you can recommend the teachers to do is to create a seating chart. Many high schools may not have assigned seating like you do in elementary school because teachers are going to have to track who was sitting where for at least 48 hours before potential exposure. And then really the health department is going to be the one sort of figuring out who should be quarantined and all of that.
Yeah, perfect. Okay, next slide, please, Olivia. Okay, so planning for non-COVID infections. I know there were a couple of chat box questions about this earlier. So, we don't have a great way to distinguish just by clinical signs and symptoms about COVID infections versus non-COVID infections. Certainly a clinical exam can be really helpful in this way. If you have a red throat, if there's, an ear infection on exam, certainly that can give you more confidence to say likely this is not a COVID infection. However, we cannot rule that out as a definitive possibility. And until there's any more point of testing in the offices, similar to like the strep and flu testing, it can make it challenging. So, some of the suggestions we had made previously to those who had asked questions in the chat box was, if you have like a clear otitis on exam or a clear pharyngitis with a strep positive, you can feel confident treating them. Now, as far as returning to school, we would probably recommend the 72-hour fever-free versus your typical 24-hour fever-free, just to be extra conscientious. Now, if there was another exposure for COVID or some other reason that, the typical infection that you're diagnosing is not fitting the mold, then I think, if you feel feel strongly about testing, then I think that would be a way to help you, but also to, if there's anything that you feel like, is not fitting the mold, or if you have further concern, then, there's nothing wrong with doing, the quarantining for 14 days. I know a lot of parents will be resistant as far as for returning to work and things like that too. But ultimately, if you're trying to protect them and also protecting, the rest of the people around them, but, I think a lot of times too, you may be dealing with parents that are maybe resistant to bringing their child into the office regardless, as we head into the winter season. So I think maybe coming up with, sitting with the fellow physicians in your office and coming up with kind of a guideline would be helpful too, about who you want to see in the office. Is there going to be any capability to do, telemedicine for some of these things? Again, it can be really difficult for kids, especially when you want to get a good look at their ears or their throat. Telemedicine isn't always the most helpful for that. So I'll just check here in the chat box here. So Dr. Peltier responded to, the sustainability of the infection, or of the contact that you would need for it to be truly considered an exposure here. Okay. So if there's no further questions about this one, we'll move on to the next slide. Okay, so this is more just information for you for testing sites. And so this came from the ODH website from coronavirus.ohio.gov about the different testing centers. The first link actually gives you all the area, so whether it's Children's Hospital based versus the ODH sites. And the second link actually gives you more of the ODH specific sites, which I know are changing almost on a daily basis as well. So these are good links to put in your favorites to kind of reference for patients, as far as the accessibility for testing. And certainly, say you have access to testing at a children's hospital or in your office for the children, but also these will helpful for parents or other household contacts of those children. Okay. All right, go ahead, Olivia, move us on to the next line. Okay, so this kind of speaks to what we were discussing earlier. So so coming up with a plan for, whether in your office directly or also for yourself about what you would like to do for, giving these children return to school, notes, and also to coming up with, absence plans. So I know some of our offices have been receiving, please exempt my child from wearing a mask, or, please allow my children, special dispensation for X, Y, or Z. And so just having kind of an idea ahead of time, what you would like to do and kind of what you feel is right. Certainly, most kids tolerate wearing masks pretty well. And, there's been no evidence that suggests that it causes any kind of hypoxia or hypercarbia. So we do think it is a safe thing for them to do, and it is for their protection, especially if they have underlying respiratory diseases. So I would strongly recommend that, unless you have strong feelings otherwise, to encourage children to wear a mask, especially in the school setting, if not, otherwise. And depending on the county and the state, there are mandatory masking guidelines as well. As far as the testing plan, Michelle had discussed this further earlier in the presentation about, for those people that have the exposure, having the 2 negative testing. Again, I think, we kind of have to come up with every office has to come up with their recommendation as far as if they want to go that route versus doing the actual symptom-based return to school. I think it also depends on accessibility for testing for those families too. I think that makes a big difference as well. But I think the big point I like to drive home for families is that there's no guarantee that if you do have a negative test, that absolutely mean that you're not going to go on to develop symptoms. And that 14 days is that key interval that you would know within which, if you were to develop symptoms of COVID. Okay, going back to the chat box here, it looks like one question, masks are required in our schools when returning. Would children have to be quarantined for 14 days if sitting 6 feet apart um, and both have masks on before one is identified as positive and kept out of school? So, that would actually not fall within the less than 6 feet for more than 15 minutes without proper PPE. So my understanding is that would not meet a criteria that the kid would be a true positive exposure.
I think you're right. I would agree with that interpretation.
And then another question was ODH says face shields are, or sorry, ODE says face shields are okay, but ODH says only for younger children. I would say whatever the child can cooperate with the best. I find that unless we're doing anything for like foreign language or speech therapy, focus, that the mask tends to be easier and most kids comply with that a little bit better. But I think some form of protection is better than none. So if there's a chance that they will not cooperate wearing the mask, that the face shield would be a good alternative. I didn't see anything listed in the CDC or the ODH guidelines regarding that specifically. And feel free to chime in if anyone knows differently. I can give you an example. My oldest child goes for speech therapy and her therapist wears a face mask. And, we wear she wears the face shield, and that we also will do the face shield when she's doing that, just because otherwise it's really difficult to see them make the sounds and do the articulation. Okay. All right. Okay. Moving on to our next slide. Okay, and so this is just more, I think we've kind of covered a lot with this presentation and have been doing our best to manage your questions as they come up. If anyone has any further questions, this is a great time to go ahead and chime in. And I do want to leave a couple minutes for Kristen to finish up with some housekeeping items she has at the end here. So looks like another question just came through. I was on an AAP Echo Talk yesterday. They said that there has not been any good studies on effectiveness of face shields. Okay. Thank you for that information.
And Deb, I agree. And I think, unfortunately, a lot of what we're recommending and a lot of the guidance we're doing, there's not evidence yet to do that. So I think we just have to sort of do the best we can.
Yeah. I've heard a lot of guidance early on that with the face shield and the surgical mask, that those are far superior than just the surgical mask on its own, especially when they're doing testing in the office and don't have access to N95 respirators and things of that effect. So.
Well, and the other thing that
Yeah,
we really other thing we didn't really address is some things like choir and band and how those things are going to happen. And I have some good friends that are choir teachers, and I've been on sort of some of their social media group chats, and they're doing some really innovative things to do. Wearing, there are masks that are a little bit, they're kind of a hybrid between a surgical mask and an N95 mask, so they have a little bit of room for people to sing, but they're doing that. They're wearing face shields. Some of them are even having sort of plexiglass around them as they sing. So lots of innovations going on.
Yeah. Great. And we'd love to keep this discussion open to, if you guys have, other thoughts that come available. And again, I think we're going to do our best to get this right the first time. I think what we've seen a lot of the guidance, at least in our area, of what schools coming out with as far as their plan for in-person versus blended curriculums is all depending on case amounts in the area. So say, for example, your zip code or your county has a really high incidence of cases, then the school district is going to go closer more to the blended curriculums or more of the truly online curriculums, versus if the case counts are lower, then certainly kind of going back to a more in-person instruction, which I think does allow for a little bit more flexibility. Yeah, and I think we covered Meredith's presentation. So, all right, Kristen, I'll let you take it away.
All right, great. Thank you again so much. So much great information. These are just some submitted questions that we received, and I think we've covered most of them. They will be in the slide deck as well as some reference and notes for you. Olivia, you can move on a couple of slides. Just wanted to mention, and again, this will be sent to you, but we do have an Ohio AAP listserv that we would love for you to join. Also, your office managers. We do a lot of support around the practice of pediatrics on this listserv where you can submit questions. And we have a lot of leadership and experts who will try to help answer that and get you resources. So that will be included for you to join. Next slide, please. Also, the chapter's COVID resource page, which I know many of you have probably seen, but we continue to update that. So always check that out and feel free to share that with colleagues and families. Next slide. And also, this will be included in your packet, but just wanted to mention that the chapter and the Managed Care Plans of Ohio are working together on a program to help practices continue to protect and preserve pediatrics during the pandemic. We want to help you recover from some of the difficulties during COVID, increase well care and immunizations, and kind of get your patients back into the office. So we have a lot of resources, practice facilitation, and things to offer. We're launching this in the fall, and I would love to talk with any of you that might be interested more about the project. So you have my email and contact information. Please feel free to reach out to me, and I'll include this as well in our follow-up information from today. Next slide, please. And these are just our social media links. Please remember to follow us. And again, we so appreciate you taking the time to join us and all the work that you continue to do for the children and families of Ohio. Again, please don't hesitate to reach out, and you will get a follow-up email with slides and all the links and a link to the recording of the webinar. So everyone, have a wonderful day and stay well.